So let's start for today. Today we'll be talking about the depot antipsychotics and with special emphasis on Olanzapine and Aripiprazole. I welcome you all and I can see many of my friends and very welcome to Dr. Seshni Maudsley, Dr. Arshad and everyone, Dr. Mohammed Asghar, Omar Habib and Dr. Syed Ahad Awais. So my name is Dr. Kamran Shaikh. I'm a consultant psychiatrist. uh, so, uh, so what we were talking about the depots last time. So we'll finish it up and then we'll talk about Olanzapine and Aripiprazole. So I'm going to share my screen now. So you can see my screen now. It is so the leftover from the last time is that there should be a yearly follow-up. And walaikum assalam, Dr. Omar Habib. Thank you. So, there should be yearly follow-up, especially about the patients on depot. But on the other hand, if they are on olanzapine depot, you should monitor very closely the glucose and metabolic screen, maybe every 3 months if possible. But otherwise, yearly follow-up is fine with the ECG and metabolic screen for everything. And generally in Ireland and in the UK, we follow up the patient 6 monthly anyway. So you also monitor them for side effects. So Glasgow antipsychotic side effect scale, GAS, and it is very frequently done in the UK by the community psychiatric nurses. And I think we should introduce it in Ireland as well, that the nurses and the doctors both should be trained in introducing GAS. And then the AIMS, so abnormal involuntary movement scale. Now the question is when to reduce the dose of antipsychotic. So first of all, try not to reduce dose. But when the patients go into an elderly age, there might be solid reason for reducing dose because their body needs become less. But even then, if they are used to the high doses, make it very, 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 very slow, very gradual, and keep them on the minimum effective dose with no side effect, or on the dose where there are no side effects. So that will be minimum effective dose, because when the side effects are coming, rather than you prescribe something as procyclidine, it's better to reduce the dose. But when the extrapyramidal symptoms are gone, that should be ideally the minimum effective dose, and you can keep your patient on that dose. So symptom-free, if the patients are symptom-free for a long time, apart from the non-distressing auditory hallucinations or encapsulated delusions, you can keep them on that. And then you can try to reduce the depot dose at that stage. And then when there is an occurrence of extrapyramidal side effects, especially tardive dyskinesia, at that time you may think of reducing the dose. Now, symptom-free for how long? Must be for years. Now you have to see like how long they are symptom-free. So the longer the duration, the safer it is to reduce the dose, but even then, reduce the very slightest dose at one time. And then if there are multiple past relapses and there is frequently there is a relapse, then it is better not to reduce the dose or be very careful in reducing the dose. And similarly, if frequency of the relapses and severity of relapse. So how long it took to treat the relapse, this tells us the severity, and how fixed and how risky and how dangerous were the delusions or hallucinations. Were there any command hallucinations? So in those cases, it will be very, very risky to reduce the depot, and it's better not to reduce. Similarly, and then so any previous dose reductions, any ongoing social stressors. So if there are ongoing social stressors, then it is better not to reduce the depot dose. And then and first get rid of additional oral antipsychotics if possible. Let's say if the patient is on a combination of suclopentixol and aripiprazole, or suclopentixol and haloperidol oral, or risperidone oral plus suclopentixol IM. So try to get rid of risperidone oral first, if possible, so that the patient is on one antipsychotic, not two. So these are the guidelines. And of course, you will make the clinical decision according to the needs of your patient. If tapering down, not more than 1/3 of the total dose at one time. So I'll make a reduction even less than that. So if the patient is on 100 milligrams flupentixol, I may reduce it to 90 milligrams or 80 milligrams. But the maximum will be 1/3. So you can't make them more than 30 milligrams in one go if the patient is on 100 milligrams of flupentixol every 2 weeks, because it should not be more than 1/3. Otherwise, there will be a relapse. Make reductions every 3 to 6 months. So once you have made a reduction, do not make another reduction in another 3 months or 6 months. So it should not be something that every month you have started reducing. And then reduction is better than total discontinuation. So if you think that this is the time to discontinue depot, please do not. Try to reduce it first and see how it goes. Because if you stop it altogether, that is, first of all, it is more than 1/3 anyway. And then if you stop it, relapse will come straight away. And then reduction is better than the total discontinuation. Stop further reducing if relapse occurs. So if there is a relapse, let's say 100 milligrams of flupentixol every 2 weeks, you have reduced it to 70, and there is a relapse, you may reduce it back, you may increase it back to 80 and see if the symptoms subside, and then keep it on 80 for good bit of time from there on. So at least another few years on 80 milligrams. Now we come to the main topic of today, which is the aripiprazole and the olanzapine depots. So let's start with aripiprazole depot. So there is no hyperprolactinemia with aripiprazole. That is the benefit. But the side effect with aripiprazole, oral or injectable, is the occurrence of akathisia. So that is the limiting factor. Now, there can be a one injection start with aripiprazole, or there can be two injection start. Previously, there was only one injection start, but now they are the pharmaceuticals, they are in combination with the paliperidone, and paliperidone lets you start with minimum oral dispensation. So minimum oral prescription, you can start the paliperidone, which we will be discussing in the next sessions, how to start paliperidone. So similarly, the company which makes aripiprazole came up with the idea of two injection start. So let's go with the one injection start, the most commonly prescribed method, and we should stick with this method. It's not available in the Asian countries, but it is available in the UK and Ireland. So let's stick with the one injection start if we can. So step one is you start with the 10 to 20 milligrams oral dose for at least 14 days. Okay, and then the step two will be 400 milligrams regular IM dose, and then 400 milligrams every month. So that is the step two. And then the step three will be, so I will correct it, that the step three will be that 10 to 20 milligrams OD as oral for another 14 days after the first injection. So you will give the same dose as an oral dose for another 14 days. Now, in the step two, the treatment can be 200 milligrams, 300 milligrams, or 400 milligrams, so depending on what treatment you want to use for your patient and what depending on the need of your patient. So the nurses may say to you that the vial comes in 400 milligrams, what to do? So if the vial comes in 400 milligrams, you discard 1/4 and give 3/4 if you are giving 300 milligrams, or discard 200 milligrams and give 200 milligrams. So the cost will be the same, but at least you are not giving more than what the patient requires, less side effects. Then it is the two injection start, and it is all derived from the Maudsley prescribing guidelines. So I must acknowledge them. They have worked very hard and made things easier for us. Two injection start. Step one will be 10 to 20 milligrams oral dose for 14 days. Now the step two will be the two loading doses of 400 milligrams each. One on one side, other on the other side. So two loading doses of total 800 milligrams or 400 milligrams each at different sites. So you give 400 milligrams on one side, 400 milligrams on one side, and then you give the 20 milligrams last oral dose of aripiprazole. Now, when you go to the one injection start, step three, that you are giving another 14 days of oral treatment. In the two injection start, you can stop the oral treatment straight away after this loading dose. So that is the difference. But by default, stick with the one injection start. Only go with two injection start if the patient is very non-compliant and they are not ready to accept any oral treatment. In those reserved cases, you might go with two injection start. Otherwise, go with one injection start. That is the default. Now, how to switch to aripiprazole? So number one will be like from other antipsychotics. So if the patient is on any other antipsychotic, whether oral or injectable, how to switch to aripiprazole long-acting injection. So the first will be cross taper. So cross taper, and then after that, so cross taper with the oral. So there is one oral. So you stop one oral, for example, risperidone. So you are reducing risperidone and started giving the aripiprazole. And then you increase aripiprazole, reduce risperidone, and then you and then that's the cross taper, which is complete now. And then if there is a two, so that is, and then after that you introduce the aripiprazole. So if there is a 2 injection start, like you stop oral after the first injection. So you have introduced aripiprazole. You have already stopped the oral, like the oral other antipsychotic, and now you are giving the oral aripiprazole for 15 days anyway, whether it is 1 injection start or 2 injection start. Now, after 1 injection start, as it was here, you will continue for another 15 days, the oral aripiprazole. While in the 2 injection start, you will stop it. So you will stop the oral aripiprazole after the loading dose in 2 injection start. So that is very simple, how to cross taper and how to switch from other antipsychotics to aripiprazole. And you're very welcome, Dr. Mark Zerub, our colleague from Malta. Thanks for joining. Now, so it's very simple. You just cross taper and then follow the protocol on the first page here. Similarly, if you are doing this start from other injectable antipsychotics, long-acting injections other than risperidone. So you will see when is the last depot of any injection. So the last depot may be due on a particular date. And then whenever it is due, you start oral aripiprazole. For example, Zypadhera 400 milligrams was due on 23rd of July 2022. So you have on 23rd of July 2022, you have introduced the oral aripiprazole for 14 days. And then after 14 days, you will give the depot. You will continue the oral if the loading dose was 400 milligrams. If the loading dose was 800 milligrams, like 400 milligrams on each site, then you will stop the oral aripiprazole. So that's the first 1 or 2 injection protocol. So if it is confusing, just remember the 1 injection protocol, because I don't want to confuse. So 1 injection protocol is that start with oral dose, give 400 milligrams regular IM dose, and then another 15 days of 10 to 20 milligrams OD or of oral aripiprazole, and then continue the injection. So that is the easiest, that is the simplest. Now, if you are switching from risperidone consta, So if you're switching from risperidone Consta or risperidone long-acting injection, not paliperidone, just risperidone. So stop the risperidone oral, because the problem with risperidone Consta is it is slow to build up and slow to wean off as well. And there is a life principle as well. Whatever is slow to come also declines very slowly. And whatever goes to the peak very suddenly, it is maybe likely that it may go to the other end very suddenly. There's no hard and fast principle, but this is generally what is seen. So, for example, if the sun is there, sun is very gradually over, like over several hours, it goes to the peak, like 6 to 7 hours, and then it another takes 6 to 7 hours for its decline. So similarly, risperidone is slow to build up, so it is slow to decline as well. So after stopping risperidone Consta, do not give oral aripiprazole straight away. Wait for another at least 2 weeks or another 4 to 6 weeks, and then introduce oral, and then 1 to 2 injection protocol, then introduce injectable. But again, there is no hard and fast rule. If you feel that your patient is likely to relapse, then do whatever is better for your patient. And you might have to introduce the aripiprazole straight away. So they are just the guidelines. They're not very hard and fast principles. Now, aripiprazole lauroxil, and we have never used it in the UK and Ireland yet. It may be something in the States. I haven't heard about that in Ireland yet, and not in the UK. So, but aripiprazole lauroxil means it's a prodrug which can be given monthly, or it can be given 6 weekly, or it can be given at a 2 monthly interval as well. And now that new injection of the lauroxil, which is 2 monthly, because again they are in competition with the paliperidone. So paliperidone made a 3 monthly injection. So what they did with aripiprazole is they changed the molecule to a prodrug, and then they tried to make it 6 weekly or 2 monthly. So it's not available, but for theoretical purposes, I will describe the doses. So 441 milligrams will be equivalent to 300 milligrams of Abilify, and 662 milligrams of Abilify lauroxil or aripiprazole lauroxil will be equivalent to 450 milligrams of Abilify Maintena or aripiprazole depot, traditional aripiprazole depot injection. And then the 882 milligrams of lauroxil will be equivalent to 600 milligrams of Abilify injection. And then 1064 milligrams will be equivalent to 724 milligrams Abilify Maintena. Now, as Aristada Initio, that is another kind of special oral formulation. So, and with that, there is no need of oral supplementation. So we don't know much about that, and something which is not very much available here. Now, And the next one, we come to the Olanzapine depot. So Olanzapine depot means that like it comes in olanzapine palmoate or olanzapine ambonate. Most commonly olanzapine palmoate, which comes as a depot. It is poorly water soluble, unlike other atypical long-acting injections. And its peak levels are achieved in 1 week. This only gluteal injection. So it is very similar to the traditional depots in that respect, that it is only gluteal injection and it is poorly water soluble. So initially, we give the olanzapine depot as a 2-weekly depot, and later we increase it to a monthly depot, depending on the dose. If the dose is very high, then we keep it at 2-weekly. If the dose is low, then we can try monthly. So it depends on the severity of the psychosis. Loading doses are recommended sometimes, but it is better to give oral trial before the initiation of long-acting injections. And you must give to check for the sensitivity, because generally we don't give test doses before the second generation LAIs. So before, the test doses are generally not given, although according to the Maudsley prescribing guidelines, you can if you want. If the patient is refusing oral treatment, you might have to give the test dose in very, very selected cases. But otherwise, your test dose is your oral treatment, because generally the long-acting injections are the second generation LAIs are not usually oil-based, so oil sensitivity is not generally a problem. So that's why test doses are not recommended. And the oral exposure to the compound acts as a test dose. And when you give the first long-acting injection of olanzapine, oral olanzapine is no more required, although you can give it for another couple of days if you want, but generally it is not necessary. Like for aripiprazole, it was necessary. So you give 10 to 20 milligrams OD as oral aripiprazole for another 14 days after injectable treatment. But here, you don't have to give the olanzapine oral after you have given the first injection. If you want, you can in small doses, but it's not required. Now the rule of aripiprazole was that no single injection could be more than 400 milligrams. But how they broke this rule was they gave it as a 400 milligrams of aripiprazole on each side as a loading dose in 2 injections start. So here the rule is again very strict. No single injection can be more than 405 milligrams dose of olanzapine. So equivalence, if you are giving 10 milligrams per day of olanzapine, 150 milligrams every 2 weeks will be the equivalent of olanzapine. And if there are 300 milligrams every 4 weeks, so it will be 10 milligrams per day. You will give 150 milligrams every 2 weeks. Or if you want, you can give 300 milligrams every 4 weeks in 10 milligrams per day dose. So how do you start the 10 milligram equivalence? If it is a 2 weekly, give a loading dose of 210 milligrams of injectable olanzapine. Then every 2 weeks, So you give 210 milligrams every 2 weeks for 6 to 8 weeks. After 8 weeks, so for 8 weeks, you will give 210 milligrams. And after 8 weeks, the next dose will be 150 milligrams 2 weekly. So you first build something oral, 10 milligrams per day for about 15 days. Then you give 210 milligrams every 2 weeks as the first loading doses for eight weeks. So you give the loading dose for 8 weeks, means every 2 weeks you give a loading dose. So the first loading dose, second loading dose, third loading dose, and then the fourth may be the regular dose. So after 8 weeks, you give 150 milligrams 2 weekly. So first injection was 210 at week 0, then 2 milligrams, then at the 2 weeks, you give another, the first injection was 210, and then the second injection will be 210 at 2 weeks. The third injection at 4 weeks will be 210. The fourth injection at the 6 weeks will be 210. And then maybe the sixth injection may come back to 150 milligrams every 2 weeks, and you continue with that. So that is the 2 weekly start. So the fourth regular dose will be 150 milligrams fortnightly. That's the 10 milligrams equivalence. Now, if you are giving 4 weekly, then the first dose will be 405 milligrams every 4 weeks for 8 weeks. So 2 injections, 4 weeks apart. So first injection at baseline, then the second injection at 4 weeks, 405 milligrams each. And then the third injection will be 300 milligrams every 4 weeks. So that means 2 loading doses of 400 milligrams 1 month apart. And then the third, after 2 months, will be the regular dose of 300 milligrams. Now, how to start a 15 milligrams per day equivalent dose of Olanzapine. So we are talking about Olanzapine. So 3 loading doses of 300 milligrams each after every 2 weeks. And then after that, you give 405 milligrams every month or 210 milligrams every fortnight. So you aim to give 400 milligrams monthly. So you can't go up more than 405 milligrams. You can't go to 600 milligrams loading dose. That's why you give the loading doses at 2 weeks, although you want it monthly. So you give it 300 milligrams every 2 weeks. After that, you have the choice. You want to continue at 405 milligrams every month or 210 milligrams every fortnight. So the rule was no single injection can be more than 400 milligram dose of Olanzapine. Now, no oral supplementation necessary after any of the Olanzapine injections, and I've already said that. So it is just an optional if you want to give. Now, how to start a 20 milligrams per day equivalent. Now, keep in the rule, no injection can be, no single injection can be more than 405 milligrams. So simply start with 3, but so what they say is that it will be every 2 weeks. You can't give it every month because the injection will have to be 600 milligrams, and you can't give it every month because you can't give more than 405 milligrams in one go. So simply start with 300 milligrams every 2 weeks. You build the 20 milligrams oral, Then give 300 milligrams injection every 2 weeks. Discontinue the oral. Simple. Okay, switching. Again, very similar principles. If you are switching from other depots or oral to the injectable olanzapine from other depots. So wait for the due date of any other depot except Risperdal Consta. Give the loading dose of olanzapine following the protocol. So something like 200, 200, 210, 210, 210, and then 150 in a few in 3 to 4 weeks time, and or whatever protocol we have discussed here. So start according to that protocol. So just when the depot dose is due, you give loading dose of olanzapine instead. And it is better to give some oral olanzapine before, but then after that, you don't need it. Now, Risperdal Consta, again, you have to wait for 15 days after the due date of Risperdal Consta. Then you give loading dose of olanzapine and then follow the protocol. Now switch from other oral antipsychotics to oral olanzapine. So that means you cross taper. You cross taper the other antipsychotics. So you first switch them to olanzapine oral by a cross taper method, then give the loading dose of olanzapine, loading doses of olanzapine, because you need loading dose every 2 weeks for about 3 weeks, and then the and then at the I think it's the 6 weeks, and then at the 8 weeks you can give the full dose, like the normal dose, not the full dose, but the normal regular dose. Now, the method 2 of switching is that continue oral antipsychotic at the same dose or make a very slight reduction. Give the first loading dose of olanzapine and then continue reducing the previous antipsychotic. So you don't have to convert it to the oral olanzapine. You just start the loading dose and continue the previous antipsychotic, and then you reduce the previous antipsychotic rather than cross tapering it with oral olanzapine first. And then you give the loading dose of olanzapine, you reduce and discontinue the previous antipsychotic, for example, haloperidol, and you build up olanzapine over 8 weeks, and then you completely discontinue the previous antipsychotic. So sorry about complicating. It seems a bit complicated, but you can always ask the injection, ask the question, and it is not that complicated. It is simple, but you seldom use olanzapine. I might have only 1 or 2 patients on olanzapine long-acting injection. But when we come to this post-injection syndrome, I mean, it is more of a hype created. So post-injection syndrome does exist, but still it's not that common. So we can have more people on olanzapine injection if required. The only drawback is that it has to be 2 weekly, like Risperdal Consta, because when you go to 20 milligrams equivalents, you can't give it more than 2 weekly, because you can't give more than 405 milligrams in one dose. So that's why you give kind of that's why you give it only 2 weekly and not every 4 weeks. So the post-injection syndrome, and the reason why olanzapine depot is not that much popular, because of the post-injection syndrome, which occurs in only 0.1% of injections, or 1 in 1,000 injections. That means 999 injections, it won't happen. And even in 1 in 1,000, if it happens, it is not usually very life-threatening, although there are guidelines and you should adhere to that guidelines because they are there for patient safety. So that means that when you give the olanzapine depot injection, some of that may be absorbed rapidly into smaller veins or capillaries. And there may be an increased bioavailability of olanzapine into the blood straight after the injection within the first 3 hours. Plasma levels can rise up to 600 microgram per liter, i.e. 0.6 milligrams per liter. That is 3 milligrams in 5 liters of blood. And that can cause some side effects. Suddenly you are giving a lot of olanzapine. There can be QTC prolongation, which Maudsley haven't mentioned, but I would say that that could be one thing. There could be cardiovascular side effects, theoretically, tachycardia, anticholinergic side effects. Maudsley haven't mentioned those, but theoretically they can occur. And then what Maudsley says is somnolence, kind of oversedation, and delirium, confusion. So it manifests itself within an hour to, or maximum within 3 hours of injectable olanzapine. So you have given olanzapine within 1 hour, the patient can go into delirium or can become very sleepy. Make sure that the patient is not driving that day. And if the patient has driven, then they have to call somebody else to take them back on a safer side. And so usually within an hour of the olanzapine depot injection, LAI, this happens. If not in an hour, then it can happen in 2 hours. If not in 2 hours, the chances are very, very slim, but it can still happen within 3 hours. That is why it is said that if you give Zypadhera injection, you wait for 3 hours, you monitor the patient, ask the patient to sit in the clinic, in the depot clinic, in the outpatient department for another 3 hours before they go home. So that if something happens, you can see and you can monitor it. And this monitoring requirement has affected the popularity of olanzapine, although this would happen in only 0.1%, i.e. 1 in 1,000 patients on olanzapine. Now you can't measure exactly the risk factors and you can't predict exactly who will have and who will not have. But there are certain risk factors which we'll discuss next. So post-injection syndrome with Zypadhera is unpredictable, but it is more common in male gender. Maybe perhaps that maybe because males get more depots and females are generally more maintained on oral. Maybe that could be the case. Or maybe because schizophrenia is a little bit commoner in males. So that may be the reason. Otherwise, I can't see any other reason. or it could be something hormonal. Now, injection site related adverse effects. If your patient has gotten bruise on first injection or cellulitis or swelling, then maybe your patient may be at risk. So you are monitoring the patient for 3 hours anyway, but you might have to be more cautious or may consider switching if the risk of relapse is not very high. So high dose of olanzapine is a risk factor, and that's why we don't give more than 405 milligrams of olanzapine in one go. Now, recommendations from the manufacturers, and I will read it out. It is from the medicines.ie, and it is from the makers of Zypadhera injection, which is olanzapine long-acting injection. So after each injection, patients should be observed in a healthcare facility by appropriately qualified personnel for at least 3 hours for signs and symptoms consistent with olanzapine, overdose. Immediately prior to leaving the healthcare facility, it should be confirmed that the patient is alert, oriented, and absent of any signs and symptoms of overdose. And here it will come the QTC interval prolongation and tachycardia as well, and maybe hypotension to some extent. If an overdose is suspected, close medical supervision and monitoring should continue until examination indicates that signs and symptoms have resolved. 3 hours after, so 3 hours the monitor. After each injection, after 3 hours of each injection, patients should be observed in healthcare facility by appropriately qualified personnel for at least 3 hours. So that means you see the patient, you give the injection, and you observe them for at least 3 hours. Now, the 3-hour observation period should be extended as clinically appropriate for patients who exhibit any signs or symptoms consistent with olanzapine overdose. So if the patient is showing the post-injection syndrome, then you may extend their period of observation for another 3 hours, for example. But otherwise, if there's nothing, you will let them go at the end of 3 hours. For the remainder of the day after injection, patients should be advised to be vigilant for signs and symptoms of overdose secondary to post-injection adverse reactions. Be able to obtain assistance if needed. So even when the patient goes home, you have to be on the phone, and they should be advised to contact the emergency department or contact you in case. And the patient should not drive or operate machinery for that day, especially for the high-risk patients. So that is about the Zypadhera or the olanzapine long-acting injection. And previous to that, we discussed about the Aripiprazole long-acting injection. And in the beginning, we talked about the general principles that the patient should be yearly followed up and monitor for the side effects, and when to reduce dose, and be very, very cautious if you have to reduce the dose, otherwise don't. And what are the risk factors when you have to be even more cautious about reducing the dose? So Any questions or any comments or any additions? No? So thank you very much for today. And we'll come with the paliperidone injection, hopefully the next week.
Kamran, sorry, can I just ask a question?
Yes, Dr. Zurub, yes.
Mark, hello, hi, good morning to everybody, wherever you are. As usual, splendid presentation, Kamran. A question, Kamran, the long-acting olanzapine, have you ever seen, or rather, has anybody perhaps ever seen any anaphylactoid or any anaphylaxis type reactions with it? And I'm just wondering what management or how this person was managed. Of course, there are the usual protocols for anaphylaxis, but I'm just curious to know if anybody has had a full-blown anaphylactic reaction on this.
On any long-acting, you mean?
No, specifically on the Zypadhera, but yes, anything else, absolutely.
Yeah, there's no
exceptionally rare phenomena, obviously. So
yeah, there's no specific protocol laid down in the Maudsley prescribing guidelines, but maybe in the, I mean, I'm not aware of any antidote of that, basically, because sometimes there is an antidote. So I'm not aware of any antidote. So it will be the general kind of principles, unless there is something available in the uptodate.com or in the other modern textbooks. So I'm not aware of otherwise any other specific. For example, with the diazepam, you can give flumazenil. So I'm not aware of any such thing here.
Indeed. I mean, there is obviously the emergency medicine protocols for anaphylaxis and anaphylactoid, but I'm just wondering if there was anything. Very good. Right. Thank you, Dr. Kamran. Very grateful.
All right.
Once
Thank
again
you
for
very
teaching
much.
us. Congrats.
Thank you. See you next week.